The association will be the recognized driving force behind making Virginia the healthiest state in the nation by 2020. We hope to pursue this vision by following this mission statement. Working with our members and other stakeholders, the association will transform Virginia's healthcare system to achieve top-tier performance in safety, quality, value, service, and population health. The association's leadership is focused on principled, innovative, and effective advocacy, promoting initiatives that improve healthcare safety, quality, value, and service, and aligning forces among healthcare and business entities to advance health and economic opportunity for all Virginians. Next slide. The board identified very specific improvement priorities that they will pursue over the next 5 years. Those priorities include reducing hospital readmissions, reducing healthcare-acquired infections with a specific emphasis on C. difficile infections, improving the patient experience in all Virginia hospitals, particularly as measured by the HCAHPS survey, and then identifying and reducing and ultimately eliminating serious safety events in Virginia hospitals. Today's webinar, of course, is focused on the first improvement priority related to hospital readmissions. Next slide. As a result of this morning's discussion, we hope that the participants will achieve these 4 objectives. 1, we hope that we will all have a shared understanding of the need to accelerate progress to reduce readmissions in Virginia. While some of the recent numbers indicate that we are making progress in this area, other states are making progress, and in some cases at a much faster rate than we are. So there is a need to accelerate our progress in this particular area. Secondly, we hope that everyone participating today will have at least one aha moment and will learn something new that they did not know prior to participating in this discussion. As a result of that aha moment, we hope that everyone will identify at least one action they will take in their organization and follow up to this presentation. And then finally, we hope that we will all understand how the data-informed, high-leverage focus areas that will be presented this morning will build on the portfolio of strategies that many Virginia hospitals and other healthcare organizations are already employing to address readmissions. So we want you to keep doing what you're doing, but we also want to add to your portfolio a couple of high leverage strategies that we think will help us accelerate the rate of improvement. At this time, I will ask my colleague Betsy Cole-Archer to review a few housekeeping measures for this morning's webinar. Next slide.
Thank you, Abraham. Slides were sent this morning via email to all registrants. If you did not receive that email, you can also access the slides through the handout function of the GoToWebinar platform. This webinar is being recorded so that colleagues that weren't able to attend the live event can have access to the information. We ask that when you dial in, or when you dialed in rather, that you please use the telephone option and use that audio pin prompt. That will help us promote discussion at the conclusion of the webinar during the Q&A session. Right now, all participants are muted. If you do have a question for Dr. Boutwell at the conclusion of the webinar, we ask that you please raise your hand, or you may ask a question through the chat function. And again, we will take your questions at the conclusion of the webinar. And I would ask that if every participant could practice either raising your hand or chatting in to the chat box who you are and which facility you represent. Abraham, back to you.
Great. Thank you, Betsy. So we look forward to many of you testing out the chat function by typing in your location and the name of your organization so we can confirm that the function works. So we'll be able to take your questions at the end of the webinar. And we see many names and locations coming through, so the technology works. Great. Next slide. It is now my pleasure to introduce our guest speaker for today and our partner in this work, Dr. Amy Boutwell. Dr. Boutwell founded Collaborative Healthcare Strategies with the goal of engaging thousands of communities across the nation to work across settings and sectors to improve healthcare delivery. With the creation of Collaborative Healthcare Strategies, Dr. Boutwell works at the intersection of all best practices and approaches to improve care transitions without exclusive adherence to any one particular model. Instead, she takes the best from what is known to be effective, practical, and efficient in improving care transitions. In her former role as the co-principal investigator of the $5 million State Action on Avoidable Rehospitalization Initiative at the Institute for Healthcare Improvement, Dr. Boutwell was responsible for the state strategy, policy, clinical integrity, and thought leadership for the program. As a result of that work, Dr. Boutwell has also served as an expert panelist and advisor to CMS, the National Governors Association, and the Academy for Health State Quality Improvement Institute. Dr. Boutwell is a graduate of Stanford University, Brown University School of Medicine, and the Harvard Kennedy School of Government, where she received a master's degree in public policy and the Robert F. Kennedy Award for Excellence in Public Service. Dr. Boutwell is a practicing physician at Newton Wellesley Hospital, attends on the medicine teaching service at Mass General Hospital as an instructor in medicine at Harvard Medical School. Dr. Boutwell, I'm glad to turn the program over to you.
Great. Thank you, Abraham, and good morning, everybody. Thanks for joining. As Abraham outlined for us, the focus of today's effort discussion is to extend our thinking about how we can take the readmission reduction work that many of you have underway and extend it into some new areas that can really accelerate progress for reducing readmissions at your hospital, in your community, and across the Commonwealth of Virginia. So for today's, the remainder of today's session, we'll go through the following sections of the presentation. We will review the case for accelerating progress briefly, and then I will present to you some data that hopefully will create some of those aha moments to have all of us think about readmissions in a slightly different way. In thinking about readmissions and looking at data in a slightly different way, we can usually identify new opportunities for serving patients in an even more effective way. We'll then move into suggestions for some data-informed strategic focus areas based on a review of the data and the data in Virginia in particular. I'll then go through a touch point on some practical, proven best practices that providers and communities and collaborative efforts across the continuum have engaged in, both in Virginia as well as across the country, to stimulate some thoughts about what might be possible, again, in the spirit of growing and developing the work that you already have underway. We'll then present to you some of the VAJAY's planned activities to support statewide learning and action over the upcoming year or so, and have some time for discussion, questions, and answers. So the case for accelerating progress. Many of you may be familiar with this data, but some of you may not be. And so again, for the purposes of getting all of us oriented to the same call to action, if you will, most recently, in 2015, it turned out that Virginia ranked 46th in the country for the amount of readmission penalties that Virginia hospitals were receiving. And again, in 2015, 67 of 79 hospitals in Virginia did receive a readmission penalty. So this is cause, of course, for some concern and wanting to improve upon that. Overall, in 2015, over $16 million in penalties were assessed to hospitals, with an average penalty of $211,000 and a maximum penalty up over $1 million. there was an expansion of the Medicare readmission penalty program, and part of that expansion is really what caused some of the performance that we see here. With some slightly more, thanks to the VHHA's team, some slightly more updated information now that we're in fiscal year 16, you'll see over here on the left-hand side, this year 68 of 89 eligible hospitals in Virginia did receive a readmission penalty, and now the penalties are up over $20 million. So last year it was $16 million, and now we're looking at over $20 million. So one thing to keep in mind that, again, some of you may know and some of you may not be aware, is that in the case of Medicare penalties, the performance of a hospital in Virginia is relative to a national average, national performance. And so to Abraham's good point, while there is certainly some improvement going on in Virginia, the perspective we need to have is, are we improving as quickly as the rest of the country? And so here's where you can see on the right-hand side of the slide, and I won't walk you through all the details, but you can see that that we need to make improvement, and really we need to make improvement as quickly or hopefully a little bit faster than providers elsewhere in the nation. In particular, you'll note that Abraham pointed out that the VHHA board has called out readmissions after hip or knee surgery, and you can see there's a very good reason for that. It's because our hospitals in Virginia here got ranked number 49 out of 51 for the magnitude of readmission penalties following that condition. And so again, it's a new condition on the radar screen, and we're going to want to spend some particular focused attention on that condition. With regard to that, it's interesting to reflect that readmission rates for this condition are not, quote, high. And so here we are in Virginia. On the left-hand side of the screen, you can see that Virginia hospitals ranked 49 out of 50. The readmission rate following a discharge for hip or knee replacement is, quote, only 5%, 5.1% in Virginia. You can see the best state in the country, Vermont, is 4.1%. So it's a very narrow range, and it's an interesting, different challenge to work on, in the sense that we're dealing with low readmission rates, but again, according to what CMS and Medicare expects, these readmission rates should be very low. So they're trying to take us from low to lower, if you will. And you can see here that of the $21 million in penalties that hospitals are experiencing this year, 11 million, almost 12 million of the 21 million are in this category of hip and knee. So it's important, and it's a new and different challenge, which is why it's really worth our focus. So in response to these particular readmission statistics, we have a goal from the VHH board to reduce readmissions, all payer readmissions, by 2020. And this is really significant because I just reviewed with you the case for reducing readmissions as coming from the Medicare payment penalties, if you will. We know, and the VHHA board has been forward-thinking and saying, as we grapple with trying to improve readmission rates and trying to help our hospitals minimize any sort of penalties that they might experience relating to readmissions, where is the field going? And so I want to congratulate and support the VHHA board's vision to say the field is really going to avoiding readmissions in general for everyone, and there will be changes over the next several years that it makes it wise and forward-thinking to really think about all payer readmissions and not stay uniformly focused on Medicare, although of course Medicare drives, the Medicare population is a very important population. So we're saying focus on Medicare and expand to all payers. The key elements, I've just walked through this. So all payer is a key growth area that the board is recommending. In addition, you'll see that we're not saying reduce all payer readmissions for heart attacks, for hip and knee replacement. It's for all conditions. And again, this is forward thinking, as many hospitals, health systems, and other provider groups and groupings look forward to entering into risk-based contracting and alternative payment models, as we very well know the future holds for all of us. And so we are taking this opportunity to say we have some specific areas of opportunity, and as we grow and develop in those areas of opportunity, let's grow our scope as well for what we can do. So let's take a close look at the data here. We're going to use data to test and re-examine some assumptions or commonly held beliefs about readmissions. And I encourage you to look at this data and say, gosh, did I know that? Had I ever thought about that? And maybe you did know that. And if you did know that, ask yourself, are we acting on this data? Are we using this data to inform our work day to day? So assumption number one is that readmissions are a phenomenon of the older adult. And here is Virginia data, thanks to our QIO partners at VHQC. Here's some readmission data based on age in the Medicare population. So again, maybe not all of you realize that there are younger adults under age 65 who do receive Medicare. And of course then everyone over 65 is commonly known to be a Medicare beneficiary. So here in Virginia, we've got readmission rates by age group, and it's excuse the circle is a little bit off here on our projection. However, what we're calling your attention to here is that Medicare beneficiaries under the age of 65 actually have the highest readmission rate of any age group in Medicare. So again, this might be something that we're commonly focused to the older adult, over 65, maybe even over 80. And so ask yourself, are we targeting based on age? And is there something we might be missing if we exclusively target based on age? Of course, there's a lot of good reasons and important comorbidities going on in that age group under 65, but it reminds us that there are these disabilities and comorbidities and special conditions that occur in the Medicare population or in any general population under 65. So perhaps we shouldn't exclusively focus based on age. Here's another great example from the VHHA data shop about readmissions for total hip, total knee replacement by age. And you can see that that we have readmissions occurring on the top two panels here are total hip and total knee replacements, replacement readmissions by age. And you can see that a lot of these orthopedic surgeries happen among 40 to 75-year-old adults. And sure enough, readmissions occur even within the 40 to 64 age group, as well as the 65 to 74 age group, and in the older adult as well. So it reminds us that, you know, even though we might see a 46-year-old in front of us, we still need to think, is this person at risk of readmission? And the data shows yes, yes, they may be. Another way of thinking about readmissions is how soon they happen after discharge. And perhaps there's an opportunity to think about our strategies, you know, in terms of what happens around the discharge planning phase, what happens on the day of discharge, what happens in the days and hours after discharge, and then what happens in the weeks following. And oftentimes we hear providers say, oh gosh, 30 days, you know, we can't control what happens, you know, 2-3 weeks out from a hospitalization. Now, certainly that is an area for continued debate and deliberation, but what's really interesting here in Virginia, and this is something I see everywhere, so it's not a unique phenomenon at all to Virginia, but we see that fully a quarter of all readmissions that do occur happen within 4 days of discharge, 96 hours. 96 hours. So if we thought about what can we do in those first 100 hours, if you will, post-discharge, what would we do differently? And if we could really focus on those immediate bounce backs, that would give us potentially 25%, you know, a solid 25% opportunity to do something a little different. and better. Another way of re-examining data is to ask yourself, how are we targeting right now, and is that informed by the data? Now, I'm sharing with you again Medicare data, thanks to our partners at VHQC, and I would add to this that as I use Medicare data as an illustration, I most certainly encourage you to think about your own all-payer data and what this looks like at your own facility and within your own hospital and system. So here, I think, is a real shocker, and I love this graph, and I think it's very powerful. We all know that heart failure, pneumonia, COPD, heart attack, and hip and knee replacements have been put on our radar screen by Medicare. Those are the penalty conditions, again, for those of you who may not know the details of the Medicare readmission penalty. Here we have Virginia data, updated. This is the most recent set of quarters available. And we see that not only is sepsis the #1 discharge diagnosis that leads to readmission, but it is #1 by a long shot, by almost 3 to 1, over the next most common condition, which we don't talk about either, which is renal failure, kidney failure. And then we have pneumonia, heart failure, AFib, etc., COPD, and on we go. So I find this hopefully is a real aha moment for many of you, and that makes sense to me as a physician. Sepsis is a condition that is very serious, and fortunately, many of your hospitals, many of our SNF partners, many of our home health agency partners are very focused on sepsis because we know how deadly it is. We know how dangerous it is. And so I think we have a great opportunity to say, whatever our sepsis focus is, there's surviving sepsis, there's sepsis quality improvement, early rescue. We have a lot of efforts in the hospital setting on early identification and early treatment of sepsis. This is the companion to that. This says, and once they leave, what else do we need to do? What else do we need to worry about? What else do we need to follow up on? What other monitoring might we want to put in place because this is such an important condition? So I love this graph, and I'm very glad that you in Virginia have this data to inspire and inform your work moving forward. A few other items to say about this diagnosis list is this is, I think, the top 10 conditions, top 10 discharges that led to the most readmissions among Medicare patients in Virginia. And what you can see also is where people are discharged to. So they've highlighted for us if patients with those conditions have been discharged to home. In this case, I'll say it in order: to home health care, to home in the green, to SNF in the blue, or to another location in the orange. And so as you'll learn through the rest of the session, we're really trying to focus on the transition to home health and to SNF, in addition to the area that many of us have been classically focused on, which is the transition from hospital to home. And so this graph also reminds us that people with these conditions are going to a wide variety of post-hospital care settings, whether it's home with home care or home without home care or into the SNF environment. And this is collectively on all of our radar screens, which is another excellent use of this graph. Because we didn't have all payer information to share with you about diagnoses, I'm sharing with you national all payer information from the Agency for Healthcare Research and Quality. And this also, I hope, will produce an aha moment for you, in the sense that we're looking here at the top 10 discharge diagnoses that led to the most readmissions in America for Medicaid patients as well as Medicare patients. And this is national data, so it looks similar to but different from, if you're looking at that Medicare list, similar to, different from the Virginia data, as you can see. So for Medicaid, I think the very most important thing is #1 is look at how different the list is. Mood disorder, schizophrenia, diabetes, complications of pregnancy, alcohol-related early labor, and there we go down at #7 is where we're usually focused today on heart failure. And then there's sepsis, which is always tied up there with heart failure, and then there's COPD, and then, again, substance use related. So think to yourself, again, in your efforts, whether you're a hospital or whether you're a community and post-acute care entity, when you are getting handoffs and when you are transitioning the care of a patient from a hospital to a community or post-acute care setting, are these conditions on your radar screen every bit as much as heart failure, AMI, pneumonia are? And this is a great use of this data. Okay, so then moving into another way of looking at opportunities to focus and accelerate our efforts is to cast away age, cast away payer, cast away diagnosis. Those are mostly the ways we find case finding, isn't it? But here's an opportunity, and again, this is similar across every state that I've worked in as well as the national data. Here's an opportunity to say, can we identify high risk just by virtue of where the patient goes after the hospital? And in this is the graph from Virginia data that shows, in fact, we can. So the gray line, to orient you, is the average Medicare readmission rate currently in Virginia, and we're running around 18.6. Okay, and you can see that down in the table if you'd like. So that's the average readmission rate, and then we see the split between these lines. So everyone discharged to home, every Medicare patient discharged to home in Virginia has an average readmission rate of about 15% discharged to home. Now ask yourself, where are you focusing your efforts? Many of us, for good reasons, are focused on the discharge to home because we're worried about people. They were just in the hospital, they're going home, they, quote, don't have services, and we want to connect them to the transitional care services that they and in-home supports that they need. That is a great idea. We should stick with it. It's been led by your efforts at the state level to train AAAs in the care transitions intervention model and to engage in self-management coaching for patients who are going home. That is great. We're adding to that conversation by saying, look at this. We have other partners and other opportunities. All patients discharged to skilled nursing facilities and all Medicare patients discharged to home health have a 20% readmission rate. And of course they do. Of course they're higher risk. They, by definition, this is a different patient population. They have ongoing skilled nursing needs, which is why they are going into home health and to skilled nursing. So it's not a surprise. It shouldn't be a surprise, nor is it any sort of indictment that the readmission rates are higher, because this is a sicker population. However, I will say, as a physician that practices mostly in the hospital, that when we're trying to put a discharge plan into place, we're trying to get this sick patient connected to home health services or to go to a skilled nursing environment because, A, they need it, and B, we think that that is the discharge plan. And what we have an opportunity to look at this data by saying, actually, the readmission reduction strategy should start at the point that we identify someone has post-acute care needs. And we need to continue and do more for that patient, because just by virtue of the fact that they're being discharged to post-acute care means that they are demonstrably at higher risk of readmission. So how can we come together as hospital, families, post-acute care agencies, and SNFs and say, how can we work together and do more for this patient population because they clearly need it? Sorry, this is a little fuzzy when it is projecting, but I think I have two more slides about data. So very quickly, one other way of looking at a high leverage population to focus on are patients with frequent hospitalization. And this is Massachusetts data, but we're also trying to run it for Virginia. And what we saw in Massachusetts is that 7% of patients who were hospitalized 4 or more times in a 12-month period. Those 7% of people who had 4 or more hospitalizations, they accounted for 25% of all hospitalizations in the state of Massachusetts. And interestingly, they accounted for almost 60% of all 30-day readmissions. Regardless of payer, regardless of discharge setting, regardless of diagnosis, regardless of all these other things, the single identifier of being frequently admitted is a great case-finding flag, if you will. That in and of itself, for whatever diagnosis, for whatever situation the patient has, that is a marker that this is a person that we should really focus in on and help. Finally, we've got a really neat map of readmission rates by geographic location in Virginia. And so I invite you to look over this map and use this in your community meetings to say, is there something about where we show up on this map that we should be concerned about? And I think it is a really great opportunity to say, you know, readmissions are can be concentrated in certain locations in the state, and certainly if you're popping up in one of the darker orange or red communities, it's a great opportunity just to say, yep, we have some work to do. Okay, so based on that quick review of data, we'd like to propose to you a data-informed strategic focus. Again, we recognize that readmission reduction work has been going on across the Commonwealth for years. Lots of good programs underway. This is not to diminish or suggest that you walk away from anything that you are doing. By all means, keep steady with what is working. And here's a set of proposals for adding some high leverage opportunities for focus together as we try to achieve this 20% reduction by 2020. So I reviewed with you, again, the Medicare rates for the sake of using specific numbers. But just want to remind everybody that we do encourage an all-payer focus, and then when you look at your own data and think about your own patients, thinking about everyone who hits these criteria would be well advised. So for the sake of going through the numbers, again, for the entire state of Virginia, we had 227,000 Medicare discharges and 50,500 readmissions. So 50,000, I'm just going to say 50,000 readmissions. The current Medicare readmission rate is 18%. Okay, so we went through a couple high leverage opportunities. Number one is, you'll remember that graph about post-acute care. Everyone discharged to post-acute care has a higher readmission rate than people not discharged to post-acute care. So in that category, we have 111,000 discharges. So about 50% or a little less of the discharges are to post-acute care. So that's a high leverage opportunity. It's a big population. We reviewed that among everybody discharged to post-acute care, the readmission rate is 20%, and so we have 22,000, roughly, readmissions occurring among patients who were discharged to post-acute care. Again, the numbers are substantial. That's 44% of all readmissions that are occurring in the system are occurring among patients going into post-acute care, which is, of course, why we're so thrilled that our post-acute care colleagues have come and joined us. Virginia, we've got about 47,000 discharges occurred among high utilizers, and about 22,000 readmissions also occurred. And now these are overlapping populations. We're not suggesting that, you know, a patient is either discharged to post-acute care or a high utilizer. So these are complementary and overlapping populations. So similarly, we have 22,000 readmissions among high utilizers. The readmission rate, though, this is what I want you to take home, is 46%. You've never heard of a readmission rate that high. We hear about readmission rates of 18%, right, for the total population, 20% for post-acute care, in the 20s for heart failure and the other top diagnoses. PS, readmission rate, you'll remember, for hip and knees, 5%. So 46%, extremely high readmission rate. Again, not unusual. This is not unique to Virginia. This is universal wherever I look. And then we have also about 43% of all readmissions that occur in the Commonwealth of Virginia for Medicare patients are occurring among patients with this criteria of 4 or more hospitalizations in the past 12 months. So it's a high leverage opportunity. And then finally, not to forget, we've got about half of the discharges are in fact to home. So this is a high volume group being discharged to home. Relatively lower rate of readmissions at 15%, but we still have 18,000 readmissions occurring. So we do not at all want to walk away from this group and not focus. We've got 35% of all readmissions are happening among these discharges to home. And again, good strategies you already have in place for that group. So what would happen if we focused in on patients discharged to post-acute care and implemented even better best practices, even stronger transitional systems than we already have? So again, this is something I think to take back to your team meeting. It's a lot to process quickly, but I wanted to present it to you so that perhaps you might replicate this for yourself at your own organization and in your own communities. So I already mentioned that of all of the discharges, 40% of all discharges are going into post-acute care, as I have circled here on the slide. 44% of all readmissions are occurring among those among patients discharged to post-acute care. So if this is the same numbers, and go down to the middle of the slide with me here where the bolded numbers are, our goal is a 20% reduction. If we reduced readmissions from post-acute care by 20%, we would be avoiding 20% of 22,000 readmissions. So we would be avoiding 4,400 readmissions. That means that there would be 17, we would quote allow, or we would expect that 17,600 readmissions would occur. However, that is a significant improvement. If we had 17,000 readmissions occur among all of the 111,000 discharges to post-acute care, the readmission rate would go down to 15.8%. So that is a big improvement for post-acute care readmission rate. And the neat thing is that at the state level, that gets us statewide improvement. That's why we're calling this a high leverage opportunity, because as the math flows out, we would go from an 18.2% readmission rate at the state level down to a 16.6% readmission rate if we made the goal in post-acute care alone. I won't walk you through it again for high utilizers, but it's exactly the same story. Again, we know these are not independent populations, but it's the same story, which makes it exciting. These are the basic stats I've already gone over with you. And if we reduced readmissions among patients with high utilization by 20%, we would also remove 4,300 readmissions from the system. We would take that 46% readmission rate for high utilizers down to a 37% rate for high utilizers. And again, at the statewide level, we would have a 16.6% readmission rate through success in a high utilizer strategy alone, such that if we theoretically added it up, and again, this is for modeling purposes only, if we added it up, we would take Virginia from an 18.2% readmission rate down to a 15% readmission rate, and adding in all of the other activities that you have, we can really see a path forward to say this is possible. Hospital-wide and statewide readmissions by 20% by 2020. We do so through a focus on post-acute care readmissions, to do best processes and practices in place for discharges to the skilled nursing environment, as well as processes and practices in place for discharges to home with home health. If we also take a unified, extended focus on reducing readmissions for patients who are frequently admitted to the hospital. And as you'll hear in a moment, a effective way to do that is really to look at the whole person, to not go down any specific disease pathway, but usually people who are frequently admitted to the hospital, they have a whole cornucopia of social, behavioral, clinical, familial goals of care issues. And what we really need to do for these people is take a look through a whole person lens and help them that way. Of course, you already have your strategies. Many of you have strategies for reducing readmissions for patients who are discharged to home. And the key statewide investment there is through the state innovation model and AAA investments in transitional care coaching and linkage to social services through the efforts that are already underway. Again, very effective, building on that. And then finally, this other focus area for those of you who are doing total hip, total knee revisions and replacements in your hospitals. This is an important focus area, and there are many practices that can be put into place to improve the pre-op, peri-op, post-op, and rehab processes and practices for those patients. So I'm going to take a few minutes to review a selection of best practices to improve the care of patients who are discharged to post-acute care, improve the care for high utilizers, and improve the care for patients who have had hip and knee replacements. This is, of course, can't be exhaustive and is really just a starting point to encourage you to look into these and other best practices and to start thinking about what might be feasible in your organizations and in your communities as we enter into the summer months. There will be future programming in each of these domains as the year unfolds. So number one is, again, we're so appreciative of the volunteer spirit that we have among our post-acute care colleagues for joining us today. And I just wanted to say a few words about how really this is a great time to be thinking about the transition from hospital to post-acute care. There are some in addition to readmission penalties, there are some other profound incentives to come together and really work on this. Our post-acute care colleagues may not be aware of another very interesting incentive that's alive and well already in the hospital industry, which is another component of Medicare payment called Medicare spending per beneficiary. And through this part of the incentive and withhold payment mechanism, hospitals are effectively exposed to seeing all patients as being in a virtual bundle. And what this means is that hospitals are judged, again, by how expensive the total cost of care is for their Medicare patients that walk through their doors. And Medicare is looking at total cost by the cost that a Medicare beneficiary incurs from the 3 days before a hospitalization occurs through the entire cost of the hospitalization, the 30 days after discharge, and they're counting inpatient, outpatient, home health, SNF, hospice, DME, all rolled in to a total cost in this Medicare spending per beneficiary score that every hospital gets. Their hospitals are judged in this program both by their performance relative to, again, a national average, as well as whether they're making improvement, which is a nice component. So making improvement does count in this particular incentive. So this is a very powerful incentive to bring hospitals closer and closer together to with their post-acute care partners, because Medicare does expect that total spending per beneficiary comes down through this mechanism. Interestingly, in the regulatory guidance, deep into page 172 of the materials that go along with this particular payment incentive, is the following quote from CMS: "There are potential for efficiency improvements in post-acute care utilization, and the conditions for which post-acute care accounts for a large % of episode payments provides hospitals with a stronger incentive to efficiently manage post-acute care services." So what this says in plain English is that Medicare is specifically trying to drive system improvement, they're trying to drive cost reduction, and drive better efficient use of resources through putting pressure on the hospitals. And by putting pressure on the hospitals, they are hoping that they will see hospitals and post-acute care agencies work together better. Very, very interesting. It is part of the vision at Medicare. So a few other key facts, and again, I won't belabor these points. It's mostly for your team meetings after. Focusing in, if we're trying to drive down total cost of care, this would go for any of you who are in a bundle, an ACO, or all of you all hospitals who are exposed to this Medicare spending per beneficiary incentive. The hospitalization for any patient who's coming back to us from a SNF is 33% more costly than the average Medicare cost of a hospitalization. This is national data. And for the key diagnoses that we're always focused on, sepsis, pneumonia, heart failure, etc., you can see that the average cost of a hospitalization, a readmission for sepsis from SNFs, is $17,000 compared to an average Medicare hospitalization cost of $8,000. So again, opportunities to improve care and specifically reduce costs. Just think about that. Every time we can avoid a sepsis readmission from a SNF, we are saving the system a ton of money, and of course, we are saving the patient from a very serious medical situation. A best practice here is inspired by something that Carolina's healthcare system developed, which was called not only a SNF warm handoff, but they called it a circle back. They, too, wanted to really get a handle on reducing readmissions and improving transitions among patients going to SNFs. And so what they did was, yes, step number one was a warm nurse-to-nurse handoff from hospital sworn nurse to a receiving nurse in the skilled nursing facility. That is not easy, but that should be on your radar screen. That is a practice that should happen. There's a lot that can go into that practice. Most notably, it's the nursing, familial, and patient care issues that the nurse-to-nurse handoff includes that very, very rarely, if ever, the discharge summary includes. So there's a lot that we can talk about in terms of making a warm nurse-to-nurse handoff effective. But most importantly, and for your consideration, if we in the hospital are accountable, if we are very concerned, if we are wanting to make sure that our partners in the SNF have everything they need to take up the care of the patient, and then we should give them the opportunity to review the material, review the patient, and then have another contact with us. So warm handoff plus, that's why they call it circle back. And what the CHC hospitals do is they call back the SNF 3 to 24 hours later, depending on time of day and shift change and all that kind of stuff, to ask the following 6 questions. I won't read them off to you, but notably, question number 6 is a game changer. Have we provided you everything you need to provide excellent care to the patient? We want to make sure you have the information, the patient appears the way we told you they would appear, that we want to give you an opportunity to ask questions and clarify, and our goal is that we have executed an excellent transition to the SNF so that the SNF says, yes, confirmed, we have everything we need. That is a game changer, and it's a fantastic best practice. Best practice number 2 is a smattering of lessons from the Pioneer ACO program and the Bundle Payment Program, for which I've been faculty for the past couple years. And what we're seeing, why am I presenting you with best practices from these other programs that you may not be part of? It's because it shows us, if we're, quote, serious, if we're serious about improving care across the continuum, what are the teams doing who are already financially on the hook? And that emerges some practices that we can then think, hey, would that be feasible for us, even though we're not in an ACO or in a bundle per se. So what is usually I see is that there is an accountable care coordinator for the population who serves as air traffic control. He or she knows exactly who's been discharged to the post-acute care setting, to which post-acute care provider. They have a contact point with the post-acute care providers, and they coordinate virtual co-management type rounds, card flipping rounds, touch base, check-ins, whatever you want to call them. There's that connection that persists beyond the discharge. Number two is I'm seeing physical rounds in the post-acute environment. So not replacing the attending physicians or the clinician that is seeing patients in the SNF, that is on the SNF staff, but what I'm seeing is that the acute care team or the accountable team is sending helpers, emissaries, into the SNF environment to check on the patient, to discuss the plan with the nurse or the social worker, and to in general check in, lay eyes on people, and make sure the patient doesn't have any issues that could be addressed in post-acute care so as to avoid a bounce back to the emergency room. Importantly, they're supporting the post-acute care staff in responding to changes in clinical status. Again, eye on the ball. What can we do in the post-acute care setting appropriately and safely that could help us avoid having to send the patient in for a low acuity situation. Where physical rounds aren't happening, I see virtual care management rounds. This is what I was alluding to a few minutes ago. The air traffic controller will convene a conference call on a weekly or every other weekly basis to run through the list of their shared patients. How's Mrs. Smith doing? How's Mr. Jones? Any changes with the goals of care? When's their anticipated date of discharge? What's the plan for services and support in the home once discharge is going to occur? How's the family feeling? These are all things that, again, just help us stay focused on all of the things that need to happen as a patient moves across the continuum. Because if we're accountable for more than just executing a discharge, if we're accountable for 30 days, or in bundles 90 days, or in ACOs an entire year of utilization, then we really need to track along with the patient as they progress through their recovery. There's some use of telemedicine consults, and then there's in the bundled programs in particular, for those of you focused on the hip and knee population, there's a very nice use of leveraging the continuum, moving a patient from home to home care, moving a patient from home care to SNF, if you will, up the continuum without going through the emergency room. And so again, there's a lot that we can do and think about. There are a few key lessons. This takes a while. This is why we're calling upon this effort now, so that we can get to our goal in 4 years. It takes a while to develop a collaborative rapport, and this is not about the hospital being in charge. This is about supporting each other in a shared goal and in the shared care of a person who needs more, who needs us to do better. And then, of course, we would learn from these teams that there is absolutely never a substitute for verbal communication and joint problem solving. A lot of teams and communities will say, well, if only we had access to the medical record, if only we had an HIE, if only we could ping each other virtually. I am 100% in support of modernized tools to get the job done, but teams that are getting success will say to a last one that this is about us working together and communicating more and helping each other problem solve. And there's no substitute for that. Okay, another best practice, I would be remiss if I did not commend to your study the suite of evidence-based, gold standard tools that the developers of the Interact model have developed over the years and have now spread nationally. And these are evidence-based tools that are extremely effective. This is, again, a talk in and of itself. I recommend that you go on to Interact's website and download their slides and their tools. But what you can see here through this illustration on the slide is that there are tools in place to identify changes in clinical status, to then communicate those changes to the responding clinician with a recommendation that says, what can we do here and now without sending the patient to the emergency room. However, if an emergency room transfer is necessary, there is an excellent checklist of information that should be sent, as well as a transfer form that can be used to standardize the communication that occurs between the hospital and the nursing facility and the nursing facility and the emergency department. And then finally, if we're trying to encourage the ED clinicians to think about treating and returning the low acuity patient as safe and appropriate back to the skilled nursing environment so we don't incur a readmission, there is this nursing home checklist that really helps educate the ED staff to say, oh, wait a second, that SNF can do IVs. They can do labs on site. They can do IV antibiotics. They can do breathing treatments. There's a lot that the emergency room clinicians don't know because it's not their job to know what the nursing homes can do. And so this nursing home capabilities list opens up an entire new conversation to say, doctor or provider, if the patient is stable, they can return to us and we can reassume the care for that individual. Here's a great example of that very thing at work. It comes from a community hospital up here in Massachusetts. It was led by the chief of the emergency room, which was really important. And someone challenged him and said, why does it seem that we auto-admit everybody from a SNF? And he said, well, I don't know. I mean, if they come to us from a SNF, doesn't that mean the SNF can't take care of them? And he thought about it, and he went to his staff, and he asked the staff, why do you guys, it looks like we're admitting 99.9% of patients who come to us from a SNF. Apparently, that's not necessary. You know, and they had a brief but profound conversation about why that practice pattern existed, and there were a lot of we'll maybe call outdated conceptions about misperceptions about, well, if the SNF sends the patient to us, that means they can't handle the patient, or if the SNF sends the patient to us, then we're obligated to admit the patient. Lots of, you know, misperceptions. So the chief said, you know what, these SNFs are telling me they can do a lot more than we think they can do. And they got all the SNFs in their referral area to fill out that nursing home checklist, and they made a binder of it in the emergency room. And most importantly, they just basically educated themselves by flipping through these nursing home checklists that, wow, we really could possibly send people back to the SNF if they're you know, low-risk pneumonia, if they're low-risk UTI, if they're a change in mental status that we've already determined what the cause is, et cetera, et cetera. We could treat and return. So the chief said, I'm going to challenge us to a simple goal. Can we treat and return safely, appropriately, according to your medical judgment? Can we treat and return more people to SNF this week than we did last week? I'm not going to tell you how many to do. There's no threshold. There's no quota. There's no mandate here. Just think about it. Can this patient be returned to the SNF? And you can see their run chart over 9 months of work, January to September of last year. Fantastic quality improvement story. They just did that. They just, as according to their judgment, not changing any standards of care except for the knowledge and the question of, can we send this patient back to the SNF? And the knowledge that the SNF will accept the patient back. And you can see that they steadily increased the number of patients seen in the ED and returned to the SNF. And by the way, that avoided all of those readmissions for the hospital. Okay, next best practice. Finally, for the transition from SNF to home, is fraught with the same dangers as the transition of hospital to home. And so we are seeing SNFs and ACOs and bundles get into the business of improving the transition from SNF to home. And here again is an example from Keswick Multi-Care, a neighbor of yours next door in Maryland, that launched transition efforts for their patients. And it's really about comprehensive discharge planning, making sure that home services are in place and appointments are made, making sure that that information is reviewed in a non-rushed and appropriate way with the patient, their family, and or their caregivers. And then they follow up. They make a phone call the day after. They make a phone call once a week for a month. And then they extend that phone call over a couple of months. And they have seen very good satisfaction as well as safety and quality results from that program. A few words now. I think I have 2 or 3 slides on best practices for managing the care of high utilizers. So it's a tough term, but you all know it's an imperfect term. You all know what I mean by that. What I mean is patients with frequent hospitalizations, typically defined as 4 or more in a 12-month period. There's no universal definition, but that's a typical working definition. Okay, so I'm fortunate to advise several dozen of these programs across the country at this point, and what we see is a best practice that's used across all of these various programs is that when a high utilizer comes to our facility, we want to know it. Remember that graphic I showed where it's a teeny sliver of people. They're coming a whole bunch of times and they're getting readmitted a whole bunch of times. But it really is something like finding a needle in a haystack in a busy emergency room or in a busy admitting service. So we need systems in place to flag the patient, exactly like we flag patients who have had a history of MRSA or VRE. We just add to that flagging system, this is a patient with frequent hospitalizations. We bring it to the attention of the team, and then they can move on to the next 3 steps. At that point, what we want to do, I mentioned, taking a whole person perspective. So often these patients are back, and was it heart failure this time, or was it their COPD this time, or was it a UTI this time, or was it a fall this time, or was it the drinking? Whatever it is, it doesn't matter what the acute presenting complaint is. And that's totally different, right, for hospitalists, I'll say. It doesn't matter what the acute presenting complaint is. We need to step back and look at what is driving this person to come in so often. It's not the chief complaint or the primary diagnosis. It's not even about the chronic disease per se, because you can think for every high utilizer that has heart failure, there are 1,000 patients with heart failure that are not high utilizers. So let us not get lulled into thinking this is just about disease management. We need to look at the social and the behavioral factors in addition to the clinical factors that really have led this person to a repeated pattern of hospital use over the past year. Often, these drivers of utilization are best defined using non-clinical terms. Okay, so once we've identified the drivers of utilization, then we need to address them. This is the spirit of teams that are having success. No need is off the table. And more importantly, we need to really understand what the patient's priorities are. And we all say that, and I know part of us, we all mean that, but it is so much harder, easier said than done, I think. And it's a real opportunity for growth and development in the healthcare community and the extended services community in general. So we need to address these drivers of utilization. That is the hard work. Lastly, part of the tools for the job that we don't have right now is this emerging use of care plans. And really the care plans convey point number 2 and point number 3. The hard work that you've done to identify what are the factors that are leading to these frequent readmissions, the social, behavioral, and clinical factors. You don't want your teams to reinvent that wheel every single time. It takes too much time. The information is too precious. You want to capture it somewhere where it can live and be used by other people in the system. And of course, you want to capture what you're doing, what the plans are to address the drivers of utilization. And again, that's a lot of work, and it should be a living document that can be developed in the service of stabilizing the patient over time. So here's a quick example of a high utilizer program at a large community hospital up here in Massachusetts. They're targeting patients with 4 or more hospitalizations in the past 12 months. At their facility, it happens to be 400 and some odd patients who have used 2,200 admissions, and they have a 38% readmission rate. So very similar to the statewide data I was showing you before. They flag them. They have this dedicated team, mostly comprised of a full-time social worker, a full-time community health worker they call navigator, with a part-time nurse, and a very, very part-time, 1 day a week medical director. And each of those team members are very essential to the work. But I do want to point out, social worker and community health worker are the frontline, day-to-day people who are finding, connecting, serving, interacting with these folks, with their clinical colleague backup. They focus and have a goal of 100% contact within 48 hours of discharge. Texting, home visits, phone calls, knocking on doors, going under bridges, going to the homeless shelter, going to the bars, wherever they find people is their job. And then they proceed with executing what you would think these patients need. They need connection, frequent contact, they need creative problem solving, they need resources mobilized for them, and the goal is not hemoglobin A1C, it's never blood pressure control per se. The goal is to achieve stability. Stability defined as sufficiently connected and using resources in the community so that they are not showing up in the hospital so very often. And then, of course, measure, 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 because these are very hard programs to run, and we need to use our data in order to continually drive improvement. Some lessons from a recent learning session that we had with high utilizer programs in New York is that they said these were their takeaways after 6 to 9 months in the field. Identifying high utilizers in real time is essential. That's what I'm saying about flagging. This is finding needles in a haystack. And we need to know that they're here when they're here, because these patients, by definition, are usually not well connected. And so we need to use the hospitalization as that opportunity to try and try again to better connect with them so we can serve them once they leave. Teams say that what we do is we take a continuation of care approach. We're not asking people to sign up for a new program, a special program, a different program. That's not the right approach for these folks. The approach that seems to be working is we're here to help you. You're coming to our hospital a lot. We think we can do more for you, and so I'm on the job to help you. Let me help you. And you just make it as seamless as possible. Be proactive, persistent, and patient is an absolute secret sauce here. We don't let ourselves say that the patient refused or they're declining. We just try and try again. We continue to try to help. We continue to try to engage. You know, obviously there's a limit there where we, you know, where it would be appropriate to stop. But really, it's that spirit of we're just going to try and help wherever we can. And then we don't over-medicalize the situation. There are, as illustrated by many of these teams, all of whom thought they need a whole bunch of doctors, they actually don't need a lot of medical problem solving so much as everything that goes along with trying to achieve stability. Finally, best practices, hip and knee replacement. We just had a webinar a couple months ago in Virginia outlining from, thanks to Centra and the Virginia Hospital Center, outlining some of their best practices, and they really, I think, had messages that are very similar to what we've been discussing so far in the call today. They say you got to understand the incentives, you got to understand the penalty, what's being measured, what are the expectations. They said understand your data. Hallelujah, we're singing off of the same songbook. They said form a committee, bring people together. This is interdepartmental work, and this is interdisciplinary work. It's not about nurses, it's not about doctors, it's not about case managers, it's not about rehab and PT. We need the whole team together, which I think is illustrative of what we can collectively bring to post-acute care as well as to high utilizers. We need to bring the whole relevant team together. Improve patient education materials. They have nurse navigators as well. And I love this insight from one of the speakers who said, review all readmissions, quote, every readmission matters. And I think that if we really embrace that philosophy and say we want to really understand why did each and every readmission occur, and it's through that pursuit of expanding our understanding of why are people coming back and what else can we do for them, that I think we will get to some really great success. So in conclusion here, we want to present to you a schedule of activities that we would love you to participate in over the next year or so to support what we're trying to create a little bit of leverage and alignment across the state. So for your consideration, the VHHA in collaboration with VHQC and the other partners would like to have us work together in these focus areas over the next year, year and a half. We'd like to encourage you, again, recognizing that you all have your own set of strategies and your own specific portfolio of efforts. We'd like to encourage an addition or a focus on the post-acute care transitions, the high utilizers, and the total hip, total knee replacement patients in parallel. We're not going to, we thought about and we want to say these are 3 areas of urgent priority that we encourage you to either expand your existing work or add to your existing work in these 3 particular areas. These are high leverage, high important areas for Virginia hospitals and communities. We'd love you to work soon coming out of this webinar on identifying and engaging with partners in post-acute care. And thank you for the post-acute care partners who are here, and we invite you to reach out to your hospital colleagues. We would invite you to engage with the VHQC, the QIO for Virginia, to engage in the cross-continuum coalition work that they are available to help facilitate, bringing groups of providers together in a community to say, hey, what can we do? What more can we do? What does the data show? Who should we focus on? They support the quality improvement methodologies. A very helpful resource available to you. And I would encourage you to reach out to VHQC if you haven't had a relationship with them already. We encourage you to continue the work that the AAAs and the SIM team is supporting on community-based care and care transitions and linkage to services and supports in the community. That is work, again, that we recognize and acknowledge is very successful. You all have been to the webinars about how successful some of your colleagues in the CCTP program have been, and that is a foundational platform for success statewide. And then we encourage you to provide, use, and interpret the data that you've seen here in this webinar and the data that you otherwise receive from the Hospital Association as well as from the QIO. You don't have to do all this data analysis yourself. You have some great resources available to you that can help shed light for your hospital, your system, your community, the stats that we just reviewed on a national and statewide basis. So with that, today is our launch of the series of Learning in Action activities. We'd love you to rejoin us in August on the 17th, where we'll focus on data and measurement for post-acute care and high utilizers. It's not exactly the same as measuring for disease-specific readmissions, and so we'd like probably somebody who leads analysis at your organization, and definitely your quality champions, your readmission champions, to join us at that webinar. And anyone else, of course, is always welcome. We plan to get together at a date to be announced yet in September for a Learning in Action workshop focusing in these high leverage areas. October, we have a webinar on high utilizers. December, a webinar exploring more of these post-acute care best practices, and then get back together again in February. And so again, please save these dates. All the webinars will be at 10 a.m., so you have the dates and the times for all the webinars, and then stay tuned for a September conference announcement, and you can hold the date for February 1st. And with that, we have 10 or 11 minutes remaining for any questions, any ideas, comments, and so I will turn it over to Betsy and Abraham to see if we have anything in the chat box to address. Thank you.
Thank you, Dr. Boutwell. That was great. We did receive several questions during your presentation that I'd like to field to you at this time. The first was during one of your data slides about post-acute care and the breakdowns of those numbers. So one viewer asked, would like to know the breakdown of what's included in that PACS category.
Sure. So again, this is something that we'll talk about on the data slide, on the data webinar, but what we're using for the post-acute care readmissions is we're saying, all we can say right now, or all we're saying on this slide, is of every Medicare patient discharged, so the hospital discharge code was discharged to skilled nursing or discharged to home with home health care. Okay? Of everybody discharged into post-acute care, what was the 30-day readmission rate for those people? Now, they may not have gotten home health. Home health might have shown up and they declined to engage, but the patient was discharged to home health with the intent that they needed and wanted home health services. And then similarly, the readmission among a patient to SNF, they might have been discharged to SNF and then discharged home on day 11, but if they bounced back within 30 days to the hospital, they are counted. So remember, it's from a patient perspective. Was the patient discharged into post-acute care, and did the patient return to the hospital within 30 days? And that's a whole area of opportunity, as the questioner is pointing out, to understand what happened to those people during those 30 days and what happened during that post-acute episode. And is there something we can improve? Is there something that didn't happen, et cetera?
Great. And I think in some of your conclusion slides, we had a question. AAA transitional coaches working with SNF discharge patients have a very positive impact on reducing readmissions. Is this something hospitals and SNFs should utilize more? I suspect.
Amen. Yeah, amen. I think I said that 5 times on this webinar. Yeah. So yes. Period. Yes. Right. The transition to home, it can, for any of the high-risk groups that we talked about today, the transition to home and the follow-up and the coaching and the linkage to services and supports in the community that can be executed by a transitional care coach is a very valuable service. The answer is always yes.
Thank you. We also have several questions that are coming in about access to recordings of webinars for this event and for future events. Yes, Abraham, we're planning to do access on our website to some of these resources and tools that we've been talking about and sharing with you. That's forthcoming, but that will be a hub, if you will, for some of those resource documents.
Yeah, so we will create a spot on our website and then send the link out once it's available that will have the recording from today's webinar. There's also been some inquiry about the earlier webinar on total hip, total knee. We'll include that on that site as well, the recording as well as the slides from that presentation.
Great. And one thing that teams, I'm hoping that you're thinking of, is bring this to your next team meeting. Encourage your readmission reduction team to listen to the webinars or review the slides. And we're so grateful for the 200 of you or so that showed up today. And you're our missionaries out there into your organizations to bring this information out to the rest of the people that that have a need to know in your organization. So thank you in advance for spreading the word.
Great. We have a comment and a question. Wonderful presentation. Is there any data on the time of day that readmissions occur? For example, do more occur after hours, and could that be an area where additional coordination could be improved?
I love the question, and the best thing about the question is you're saying, what can we find in the data that would help us improve, that would help us take the next step? So I think most certainly identifying, or I think with the, I think with the QIO data I know I've seen day of week, and it may be possible to do time of day. But what I would say is, even if you took a sampling of your own data to say this week, or last week or last month, run all of the patients that were discharged to skilled nursing, all of the discharges discharged to home with home health, and then of course what you would want to see would be actually the timestamp for when they came into the ED. So it's a little bit complicated, but I love the question, and one thing I can answer is that we all think that discharges on the weekend are high risk of readmission. And they are. However, discharges on Tuesdays and Fridays, for some reason, have the most readmissions that follow them. Friday makes sense to me. Tuesday doesn't make sense to me. And so again, it's just more information to gather and to think together about.
Great. There's kind of a logistics question that for all participants. Since I registered for this webinar, will I receive invites for future webinars? Yes, this will be the list that we will work from for the future invites. So stay tuned for next presentations. One other question for you, Dr. Boutwell. Have you heard of any particular successes from use of extensivist clinics?
Extensivist clinics?
Yes.
Okay, so yes, there's an emerging practice. I don't know if you're using this term extensivist in the same way I've heard it, but yes, some we'll call them accountable entities, which would include SNFs making this decision for themselves. Some hospital, ACOs, bundles, and some SNFs for themselves have hired, I mean, extensivists, what a funny word, right? Doctors, yeah. Internists, providers, people who know how to take care of patients, and very much have them see the patient in the SNF almost like a step down type of a pattern. So they would see the patient the day or the day after they were transferred to the SNF, and frequently during the first week, and be very much involved in the clinical management of the transition from SNF to the next setting of care. And that is a great practice. There are some great examples, again, from your colleagues next door in Maryland, and I suspect many of you have piloted this as well. And so where you have an option to think about that, it's a nice option. And of course, it could be seen as a potentially expensive option. However, balanced out by the avoided readmissions from the post-acute care setting, there could be a very nice logic there.
Thank you.
So we have about 3 more minutes with access to Dr. Boutwell. So if you have questions, please do type them in, or you can also raise your hand if you have called in over the phone line, and we could answer your question that way.
I do see a hand.
I do too. It does appear that that participant is called in over the computer, so I don't know that we'll have audio access, but we will try. Maria, did you have a question for Dr. Boutwell?
You could always chat it in as well, Maria.
Right.
But as we wait for other questions, Betsy, maybe you can make a few comments about the survey that will appear once folks conclude the webinar and follow-up communication.
Yes, we of course want to work with the readmissions champion at your facility, whoever they may be, and the survey attempts to capture that information. It's 5 questions. We do want to have your remarks about how the presentation went for you today. We do want to capture your aha moments and even your follow-up action items. So a survey will pop up when you close your browser, and we just ask that you complete that 5-question survey to tell us how we're doing and to capture some more information. And we have a question that asks if Dr. Boutwell will conduct the remaining webinars.
Dr. Boutwell?
I would very much like to. I think I've been invited to do that, yes.
Yes. Well, on behalf of Dr. Boutwell and my colleagues here at the association, we would like to thank everyone for joining us today. We will be sending out notices in advance of all of the upcoming webinars and the in-person events. So there will be sufficient and adequate notice about any and all of the upcoming events in this Home is the Hub series that we'll be running for the next year and a half. So we, again, thank you all very much. Feel free to reach out to us if you have questions or concern, and we hope that you enjoy the rest of your day. At this time, we will conclude the webinar. Amy?
Yes.
Can they hear us?